is the Secretary General of the Association of Anesthesiologists of Uganda, the AAU, which is the association that is organizing this CME this evening. And also with me, I have Dr. Peter Agaba. He's an anesthesiologist and intensivist and lecturer in the Department of Anesthesia and Critical Care. And also emergency medicine. Areas of interest include perioperative medicine, neuroanesthesia, neurocritical care, intraoperative neuromonitoring, retrieval medicine, and antibiotic stewardship. He's a member of the AAU, CANEXA, and intensive care medicine. Also with us is Dr. Mwanje Arthur. He's an anesthesiologist and intensivist at the Mulago COVID ICU. He's a visiting consultant, intensivist at MedPal International Hospital, a researcher with a bias in intensive care medicine. He's a Thrive Scholar at Makerere University and a director at Hirain's Medical Solutions. So he's a scholar, clinician, and an entrepreneur. I'm very excited to have these people on the panel today, and it's going to be a very exciting session. Thank you all for logging in. I'll now set the ball rolling by asking Dr. Cornelius to start with this discussion. Thank you, Dr. Cornelius.
Thank you, Phiona. We welcome everyone to this CME. Thank you, Phiona, for that very generous introduction. So we are going to dive right into the topic. And I do recognize that there may be a lot of people on the CME that do not have a lot of knowledge and experience with this particular topic. So I'm going to try and make sure that I break down the different aspects of it, at least enough for us to understand the strategies that we shall be discussing later on. A disclaimer is that this CME is not going to equip you with enough knowledge to be able to do mechanical ventilation in COVID-19. It will, however, provide you with the principles that ICU physicians follow in management of ARDS patients, and also it will allow you to have at least a baseline understanding of what happens to patients and what we usually do to try and get them out of the ARDS that they're suffering from during COVID-19. We shall talk about the challenges and the strategies that we use for low middle-income countries and settings and low-resource settings, because this means that not all the recommendations that are coming from the high-income countries necessarily will be applicable in our setting. So just to jump right into it, I have no disclosures for this particular talk, except that, like Phiona said, I happen to be a technical advisor on respiratory care to USAID. So it has nothing to do with this presentation, but I did get some of the educational content from the group, and all that I included here, some of which is also on the website Open Critical Care that came from the result of that project. So since this is going to be a very interactive session, I'm going to ask everyone to log in. On your screen, you can see Paul EV/Cornelius Sen 033. I would like you to enter that into a web page, and then you'll be able to join in and be able to answer this poll. So I will give it about a minute or two, and then we shall proceed. So most of the interaction is going to be between your answers and then what the literature says and then what the panelists think. And that is how we are going to go through this session. And then at the end, it will be open for questions and comments from the audience to the panelists, and we shall see how to go through that. So I would like people to send in responses so that I know that you're logged on, because there are going to be about other seven other questions that we are going to have. Okay, so that is most people are responding now, I guess. So answering this will hit a saturation point. It will probably cover about 40 participants. So the faster you answer, the more your response will be captured. So once it hits saturation, it will stop. So we now have 50-50. Should the lockdown be extended? The majority are saying no. Okay. All right. I'll probably wait for this to hit saturation so that I know that probably at least 10 people, 40 people will be responding to the questions. Okay, should we extend the lockdown or should we open up and see what happens? The majority are saying no, no extension to the lockdown. Okay, the president is about to speak, maybe in about 3 days, and this is probably going to be key in whether we extend or not. Of course, these results will not go to the president, and these results are purely anonymous. No one will know that you answered this question or the question that will follow. So don't worry about privacy and anonymity. Okay, I think I'll stop it at that. We shall take it that the no's have it. So a majority of the attendees on this, out of 133 attendees, we have about 40 people who have responded to this, and the majority of you have said no. So I shall close the poll at this point. Okay. All right. So this is how it's going to run. So what about our panelists? Dr. Peter Agaba has been introduced. Dr. Erasmus Okello is also an intensivist, and he does largely intensive care medicine in his practice, and he's also a lecturer at Makerere University. I think we can hear from what our panelists think. Yes, no, or not sure. I think that's what we would like to know what you guys think. Dr. Agaba, Peter?
I don't know.
You don't know? Dr. Erasmus Okello?
I think I share the same opinion with Peter. I don't know, because we haven't done much to be ready for the next thing.
All right, Dr. Mwanje. I think you'll have to unmute yourselves so that you can be able to speak. I do not know if you're unmuted. Okay, I think Dr. Agapita doesn't know. Dr. Erasmus, we didn't catch a response, but Dr. Mwanje, we also didn't catch a response. But this is how we are basically going to go through this. So let's go into the outline. Diagnosis of ARDS, we are going to look at what the diagnosis is and whether we can do it in a low-income country or low resource setting, and then looking at ARDS pathogenesis and pathophysiology. Is COVID-19 any different? And is the cytokine storm actually a myth or is it real? And then intubation criteria in low resource settings. When should we consider intubation? How long should we wait in silent hypoxemics? And then ventilation ARDS, and then looking at whether it should be any different from COVID-19 and what are the challenges and strategies in low resource settings. So first of all, I want to say COVID-19, while it starts in the lung, is actually a multi-systemic disease that affects the brain, affects the kidneys and the liver, the gastrointestinal system, causes a lot of coagulopathy, affects the heart, and then definitely endocrine system with hyperglycemia and DKA in some patients, and then definitely the dermatological organ, which is the skin, will also be affected. Was written in Nature, and I would urge everyone to read it up about extrapulmonary effects of COVID-19. I'm mostly going to focus on the pulmonary effects. So that's what the talk will be about today, and how we handle the pulmonary effects. So ARDS has been around for almost 50 years now, moved through multiple definitions, and this is the latest definition from that's called the Berlin definition for acute respiratory distress syndrome. The previous definition was a joint consensus between the Americans and the Europeans. And it had multiple flaws that led to correcting it to saying it's an onset within 7 days of the clinical insult with new or worsening respiratory symptoms. And then it also comes with bilateral opacities that are consistent with pulmonary edema on chest radiographs, OCT. There is a caveat to this. Not all ARDS is actually bilateral opacities, which maybe this definition may change eventually. And then, of course, the use of PEEP of at least 5 centimeters of water. The problem with this is that not every time that you're going to diagnose ARDS, you will have a PEEP on a patient, especially in low resource settings, and we are going to look at that. And then, of course, it's categorized or it's classified as mild, moderate, and severe based on the PF ratios. And the PF ratios really come from doing a blood gas analysis where you get the partial pressure of oxygen that's the oxygen that's dissolved in the plasma. And then you compare it to the FiO2 and those different ranges. So less than 300 is considered ARDS as long as the clinical insult and the opacities have been identified and the patient is on at least 5 centimeters of water. And then between 100 and 200 is moderate, and severe is less than 100. And of course, the biggest challenge in our setting is actually applying that because of lack of blood gas. So we are going to go through a case scenario. This is a 62-year-old lady who comes in with progressive shortness of breath and cough, fever, chills, diffuse muscle aches, and onset about 10 days ago when they tested COVID-19 positive. They have severe bilateral creps and their heart rate is 115, the tachypneic at 27, and the blood pressure is 113/68. They appear quite ill and cyanotic. They're using the accessory muscles as well as SpO2 and room air being 77. However, on non-rebreather mask, they improve to 85% with 100% oxygen being delivered to them. They weigh about 60 kilograms and their height is about 157 centimeters. The chest X-ray is the one on your right here. So this patient is admitted to the ICU because there is a possibility that they will require advanced respiratory support based on the grounds that their non-rebreather mask
Dr.
is
Cornelius.
not delivering enough oxygen to be detected via pulse oximetry. So,
Dr. Cornelius,
yes.
kindly adjust your microphone or something. There are people who can't hear you clearly.
Oh, I'm sorry about that. Okay, let me.
The volume is low, eh?
The volume is low. Just a second. Can you hear me now?
I can hear you clearly.
Am I loud and clear?
Yeah.
Okay. All right. So let's answer this question. I hope you can all hear me. So does this patient have ARDS? The lady that we've just talked about. Fiona, can you hear me now? I had to take off my mask just so I can be relatively loud.
Yes, I can hear you clearly, but the feedback
Okay.
I was getting that other people can't hear you.
Oh, I apologize for that.
Mm.
All right, so does the patient have ARDS? 82% are saying yes.
Cornel,
yes.
should we
Yes,
be
Peter.
seeing the responses live because we can't see them?
Oh, you can't see them live?
They are not showing up.
Oh. You should be seeing them live. I'm not sure why they're not showing up. But from what I'm getting, I'm seeing them live. I don't know if anyone else is. I'll just read out the responses. What I'm seeing here is that 81% have said yes, this patient has ARDS, and a very small percentage is saying no, and another small percentage is saying not sure. So I'll proceed so that maybe, let me just try and adjust something here. I think I may have, show responses. Can you see them, Peter?
No.
You can't. All right. Sorry about that. Again, about 84% now are saying yes. So we shall move forward. I'll try and see if I can fix that as we go along. Okay, so let us go into our panelists. Dr. Peter, Dr. Erasmus, and Dr. Arthur Mwanje, what do you think? Majority of the audience has said, yes, this patient has ARDS. What's your take on this?
Maybe you could just share the picture again, Dr. Cornelius.
The picture of the patient?
Yes, the picture of the the picture with the case.
Okay.
The picture of the case.
There.
Yeah.
Dr. Peter, what do you think?
I want to give Mwanje a chance. He hasn't said anything.
Okay, Dr. Mwanje, Arthur, we'll come back to you, Peter. Dr. Mwanje, are you there?
Yes, I'm there. Hello.
What do you think about the definition of Berlin and then this patient?
I would say the patient has ARDS.
Okay. Dr. Erasmus?
I like the question you posed, does it matter? And I guess I want to take that route. This patient has got extensive airspace disease following what appears to be an acute febrile illness, and now comes with these infiltrates with hypoxemia, which is not responding perfectly well on quite a good amount of oxygen. This picture put together these different syndromes is consistent with the number of definitions that have been advanced for ARDS. So yes, the patient satisfies a number of criteria for ARDS. However, does it matter? Is, I guess, the question we should be discussing eventually. Thank you.
Dr. Peter?
Short answer.
Does it matter?
Yes. Does it matter? Well, I guess you could make a case for either answer.
Okay, so you said yes. So would you mind making a case for saying yes?
Yeah, if I think, well, I think it matters in the sense that it means that now it puts, what it does, it begins to focus how you think about managing this patient. And if you do decide to put, or if you can mechanically ventilate this patient, then you're going to go down a certain path. If you didn't think this patient was had ARDS, then you may not, make the considerations for protecting that lung.
Okay, all right. Thank you so much for that. I think it does matter. And we are going to go through some of the aspects. So a team in Kigali with Beth Riviello decided to try and modify the Berlin criteria, and they called it the Kigali modification of the Berlin criteria. And the thing about it is that yes, it's still within 1 week of clinical insult with new or worsening respiratory symptoms. The problem here is that we don't have a lot of blood gas analysis in low resource settings. And so using the PF ratio may not be ideal to be able to categorize who has ARDS and who doesn't. But the SpO2 FiO2 ratio has been used as a surrogate for the PF ratio. And so while the PF ratio, which is the PA2 FiO2 ratio, is less than 300, the SpO2 FiO2 ratio of less than 315 is considered as a surrogate. And then the other aspect is PEEP. Now, the previous definition that was a consensus between the Americans and the Europeans did not have a PEEP requirement. However, the Berlin definition did. So the Kigali modification is really more consistent with the previous consensus. And then, of course, the chest radiograph OCT we hardly have CT capacity here, and chest radiographs may not come so easy, although they come much easier than having a CT scan. So the the Kigali modification included ultrasound assessment of these patients. They are basically both the same in terms of origin of the edema. However, in terms of classification, whether this is ARDS or not, that's where perhaps the Kigali modification may fail. So if we look at the mortality associated with mild ARDS is about 27%, and it starts to increase if you have moderate and if you have severe. So patients who have severe ARDS have about 45% chance of mortality. So if we look at the Kigali modification, on the other hand, we still have a problem because they did not assess the expected mortality in relation to the Berlin definition, and therefore they recommended that we need more data to see if actually the correlation is consistent with the Berlin definition, and therefore perhaps we could replace the Berlin definition with the Kigali modification going forward. So, and then of course, with the single center study, so there is room to do this in our setting. So does our patient have ARDS? Based on the criteria of the Kigali modification, the answer is definitely yes. Although we cannot meaningfully classify it in terms of the probability of mortality, whether it is 27% or 45%, at this point we cannot actually do that. So if we go into the pathogenesis, there are a lot of insults that can happen to the lungs: infection, aspiration, sepsis, trauma, and so many other insults that could happen. If you want to categorize them, it can be pulmonary and extrapulmonary, and any way you want to do it. But all these insults lead to an inflammatory state that occurs in the lungs, and you have alveolar capillary membrane injury, permeability happens, and then you get pulmonary edema that may eventually lead into multiple organ failure, pulmonary fibrosis, or vascular destruction itself. And this is one of the most lovely images, I think, that expounded on the injury at the alveolar level. So if you consider the left side being a normal alveolus, it has a very nice basement membrane. It has a type 1 pneumocyte, and then it has a type 2 pneumocyte that's supposed to release the surfactant, as you can see right there. And then it has a very nice interstitium right there with transport proteins attached to that. And then you, of course, look at the capillary here. The cells are moving on through well. Once you get injury for either human infection or gastric contents or trauma, then that will activate the macrophages, and those will release TNF and IL-6 and IL-8 and all the other cytokines that will cause a lot more neutrophils to show up and then cause a lot more inflammation, causing a lot of permeability, and you have not just interstitial, but also alveolar edema, and of course, injury to the basement membrane and to the surfactant. The surfactant is really supposed to keep your alveolus open, and so you may start to get lung collapse in the process. And of course, that leads into a vicious cycle of having a lot more inflammation happening in that area. So the question is COVID-19 actually similar to this? If you look at COVID-19 pathogenesis, definitely it's quite similar to that. It goes through the S2, like we all know, and then type 2 alveolar cells that are supposed to release surfactants are injured. And that's when you start to get symptomatic. That's around day 1. And some patients end up getting interstitial edema, which may be happening in the early phase. About day 7 to day 10, you tend to get a lot more severe disease. At that point, you have serious destruction, both on the vascular side and on the that's the endothelium. And then, of course, on the alveolar side, and patients start to get symptoms akin to ARDS. And so that's when most patients, we may have to escalate treatment. If you look at it at the cellular level, of course, the S2 receptor is how the virus enters the cell, and it definitely allows the type 2 pneumocyte, of course, causing cytotoxic effects directly into the cell, causing damage. It's been shown to actually downregulating the S2 receptor means you're going to have little breakdown of angiotensin 2, and that causes a lot of inflammation, vasoconstriction, increased vascular permeability, and then definitely injury to the endothelium will also cause thrombosis to happen, and inflammation within that, because you have a lot of fibrin deposition, you may get microvascular thrombosis. And then, of course, eventually you have a dysregulated immune response, and that eventually leads to an inflammatory state and what is called a cytokine release syndrome. And I know this is the same paper that was published in Nature and elaborates on the pathogenesis of COVID-19. And of course, that brings us to the question of whether the cytokine storm is real or is it a figment of our imagination, because we like to say cytokine storm and it sounds exciting. Not on the patient side, of course, but mostly on our side, because then we start to think of what treatment we can use to overcome the storm. However, this study that was published in the JAMA recently showed, again, consistently low cytokine levels, TNF, IL-6, IL-8, compared to diseases like sepsis with ARDS or sepsis without ARDS. Even trauma has some level of increase if you compare the cytokines. So it is not actually a cytokine storm. There's not been any evidence to validate the term cytokine storm. And so we may find that some of the treatments that we use may not actually be as effective as we thought they would be. And so we have to be very cautious when we are going to use them and look at also the cost benefit. So if you look at the hallmark being hypoxemia as the pathophysiology of COVID-19 ARDS, there's definitely impaired pulmonary blood flow as a result of the microvascular thrombosis, but also in some areas of the lung, we have a protective mechanism called hypoxic pulmonary vasoconstriction. When you have reduced oxygen to the alveoli, the body tends to vasoconstrict the pulmonary supply to those particular regions to allow that supply to descend to the regions that have more oxygen, which is supposed to happen. However, there have been some studies that have shown that this particular protective mechanism is impaired, and therefore patients tend to have an increased shunt, which is what we are going to talk about next. And so that can come as a result of interstitial edema, which mostly in the early phase, and then alveolar edema in the later phase. Atelectasis and consolidation, of course, are part of the cascade, and all of this leads to a massively increased shunt that worsens the hypoxemia. And then, of course, let's not forget the vacuumism that comes along with all of that, including increase in functional dead space in patients. So if we look at the phenotypes in ARDS, this has been going on, I think, for 1 year now. Those who believe in it and those who don't. What we know is that classical ARDS is also heterogeneous, and there are so many phenotypes within it. At least 2 have been identified, being one that is hyperinflamed and one that is not. However, COVID-19, Gattinoni came up, or at least after assessing about 12 patients, he found out or realized that there were those that had the L type and the H type. And how these are defined, if you look at A up here, the image A, you have mostly an aerated lung, the dark areas. And when you look at the partial pressure FiO2 ratio, is actually low, almost as low as those that have a lot of alveolar edema. So the categorization for the L and H type are based on 4 characteristics. That's elastance. Basically, if you think about elastance, it's like trying to blow air into a balloon. The small balloons are very difficult to inflate. They almost collapse immediately, while the big balloons are really easy to blow air into. So that's elastance, the opposite of compliance. So in other words, the smaller the balloon, the lower the compliance, the larger the balloon, the better the compliance. So elastance being low in this category means that this patient has very good compliance, and that was what he was saying. And then the VQ mismatch is low. The VQ ratio rather is low in this category. In other words, they have a lot. The perfusion is a lot higher. Whether is a lot lower. Sorry. While the ventilation is actually higher. So they attach that to possibility of microthrombosis. And then of course the lung does not look like it's fluid laden. So it's based on the CT scan, the weights are actually much lower. And then the recruitability of such a patient is actually limited because most of the lung is aerated. So that is what Gattinoni came up with. And then, of course, they went into a debate. Gattinoni released a paper which talked about a different style of ventilation for COVID-19 L-type. And he mentioned that we should intubate these patients early. And that was not consistent with what Martin Tobin thought. These two are the gurus, or one of the two gurus in intensive care medicine, especially respiratory care. And if you watched the court rulings for the American black man who was killed by the police officer, Martin Tobin was a key witness on the side of the plaintiff regarding his death, and actually perhaps gave a witnessing that led to the conviction. So again, there was, after that release, Gattinoni releases a paper that talks about PCLI, that is patient self-inflicted lung injury that perhaps leads to injury in spontaneously breathing patients, and had talked about why it may be important to intubate them early. And of course, there was a rebuttal, and this kept going on and on between the two men until other experts in respiratory care in intensive care medicine came in and did a study of about 300 patients and from 7 hospitals in Italy, and then compared them with the LungSafe database that led to the release of the ADSNet that revolutionized the way we ventilate patients. And so in this, what they actually found, if you look at these box plots, there was actually really no difference in terms of the compliance and in terms of lung weight between classical ARDS and COVID-19 ARDS. And so they said, since there's no difference, they shouldn't say COVID-19 is any different. And so we should treat it the way we have always been treating ARDS. Gattinoni later on released a study with a slightly bigger population, about 32 patients, and still was able to show that patients, if you looked at patients who had the same level of oxygenation, which is based on the PF ratio, the ones that had COVID-19 tended to have a higher compliance compared to those that had the traditional ARDS, or what is known as traditional ARDS. And when he kept the compliance constant between the two groups, he found that the COVID-19 patients tended to have a much lower oxygenation. And so he tended to subscribe that, yes, COVID-19 is ARDS, but it's a subset, and therefore we find higher compliance and more lung gas volume for any given oxygenation level, which is based on the PA to FiO2 ratio. So it's controversial on this, but generally the world has not actually changed the way we are managing ARDS. But just to know what your opinions are, I think we can take a look at this. If you can see the question, please respond to whether you think COVID-19 ARDS is any different. I will let you know the results in case you can't see the results. Peter, can you see the results as they're coming in?
No, can't see them.
Can't. Yeah, let me see if I can change something here.
It seems you haven't started the presentation, because there is that notice there that says start the presentation to see live content.
Start the presentation to see live content.
Yes.
Interestingly, maybe what I'll do is the next, once the answers here have come in, I will get out and then get back in just to see if that helps, because I'm seeing the results now. Yeah. So for the results I'm seeing right now, the majority of the responses are actually saying COVID-19 is different. 53% are saying it's different. 24% are saying it's not different, and 24% are saying they don't know. Yeah, we shall give it about a few minutes, or rather a few seconds, and then stop it. Okay, I think it has reached saturation. 50% have said yes, COVID-19 is different from classical ARDS. And this is where we now are going to go into our panelists and ask them what they think about the H phenotypes and whether they've seen them. Are they real or are they a figment of our imagination? Yes, Dr. Peter, Erasmus, and Mwanje, I'll hand over to you to the moderator.
Yeah, we can start off with Dr. Erasmus. What has been your experience regarding these phenotypes?
Why don't
Dr.
I go
Eras?
first?
I hear Peter.
Okay, you can have Peter.
No, I just don't want to go after Erasmus. So I think what is unique about COVID-19 is that we are seeing tens of hundreds of patients with the same disease coming into the ICU. So we begin to notice patterns. Whereas before we have been getting ARDS patients with multiple causes. So what do I think about the phenotypes? I think we see a varying type of patients. At one end of the spectrum, you've got the L phenotype, and at the other end of the spectrum, you've got the H phenotype. And really what we're seeing is a progression of the disease. The patients come in, and when they need the ICU, they come in at the stage at which they're having viral injury, but they're also now beginning to have the host immune response kicking in. And that's where the injury is coming from. And then as the disease progresses, then the lungs get sicker, then you begin the pattern or the type of mechanics that you get with the lungs begins to change. And as they progress, they move to the end of the spectrum where you have got patients with very poor compliance. And so if you have someone who then goes and looks at patients and you find that you can actually put some patients in the category that comes in earlier with lungs that are not really that damaged, but still have got a very bad VQ mismatch, and you have got really bad hypoxia, but the lung mechanics are good. You can ventilate them and the compliance is not that bad. But then you have the other patients who have been sick maybe a bit longer, or the disease has just, been really terrible to the lungs. Those ones are, you have now got lungs that have got, although there's hypoxia and there's VQ mismatch and there's whatnot, but the lungs now have sustained more damage and are more difficult to manage on the ventilator.
Is this the kind of triad that you see with the traditional ARDS, or is this something that is special to COVID?
So it may not be special to COVID, and I wouldn't want to say that the other diseases are different, simply because I think with the other ARDS patients, we probably get them in when they have come in, or these diseases tend to cause hypoxia at the end of the spectrum, whereas the COVID-19 seems to cause hypoxia a lot earlier. And that's what brings them into the hospital or to the ICU. So we get them earlier. But if you have the patient who has got sepsis and then develops ARDS, they get the ARDS at the same time they get the hypoxia. I don't know if you understand my meaning.
Thank you very much, Dr. Peter. Dr. Mwanje, could you weigh in on this? CARDS versus traditional ARDS?
Well, thank you, moderator and the presenter. I think COVID ARDS is quite different from classical ARDS from my experience. A reason being, you likely to predict the outcome of the classical ARDS, but this CARD is unlikely to be predicted with actually even relevant information that has been given as far as classical ARDS is concerned. They tell you that if it's a mild ARDS, the mortality is likely to be this. If it's severe, the mortality is likely to be this. Now, this is unlikely with COVID patients. you might not predict the mortality, whether the ARDS is mild, moderate, or severe, and that makes it different. Another thing is all patients present differently. A cohort of classical ARDS might give you a uniform kind of outcome, but these patients who have CADs, all of them present differently. If according to my practice, you can't predict what can be the outcome of the next patient after you've treated one patient. So it involves a lot of critical thinking in managing these patients as regards to the outcome.
Thank you very much, Arthur. And we shall hear something from Erasmus. Dr. Erasmus, the floor is yours.
Thank you very much. I honestly want to agree with Peter. Boy is quite bright. In all honesty, I first of all, what is ARDS? When we start to boil down a syndrome into just some physiological parameters like compliance, elastance, and so on and so forth, I think we miss it. Remember, this is a syndrome, a constellation of multiple issues put together just for us to speak to one language. In others, there's no disease called ARDS. What we have is a constellation of symptomatic presentation of different diseases that compromise oxygenation through an inflammatory pathway. So in the end, we don't really have a disease called ARDS, and trying to define what classical ARDS versus what CADS is and so on, I think is a fail in our own right. And in all honesty, I don't think the question will be valid in that respect. However, just to be relevant to this, does COVID ARDS differ from the other? I don't think it differs. Like Peter said, I think we're getting patients at different stages of inflammation of their lungs and disruption of oxygenation alike. And different conditions, probably given the same chance, will probably cause the same. We're dealing with a disease that affects the lung primarily, and then has got a systemic effect, versus diseases that might affect systemic aspect of the body, then eventually launch onto the lung. When you have multi-organ failure and the lung is affected as part of multi-organ failure, that's a little bit different in terms of how soon patients will present, and therefore the lung mechanics will vary quite differently as well. I don't know if the L and H segregation of patients matter so much. I believe that a patient needs to be assessed upon presentation, and treatment should be tailored to exactly that. So if they've got great compliance, they've got well-aerated lungs, treat them as such. When they come in with lungs that are flooded, treat them as such. And therefore the L and H dichotomy ceases to matter. I think patients are continuum, right from people who are well-aerated to people who are extremely opacified in terms of their lungs and with very terrible lung compliance. And the same thing will happen to ARDS due to COVID and ARDS to any other condition given enough time. It's just that some other conditions kill patients earlier, or some conditions kill patients later through a pulmonary pathway. And that's where we see the difference that we are trying to define as classical versus CADS. I don't think it's correct to define these things either based on mortality, because remember, mortality will be an aggregated outcome of all the multi-system involvement, of which ARDS is just merely one thing. Yes, you can try to glean out and say, okay, fine, I can adjust for this and this and this, but you can imagine in our setting, patients are dying from multiple complications of COVID, some of which include hypoxemia. And I will tell you, probably it's been a while since I saw a patient dying of hypoxemia due to ARDS, due to COVID, but from other reasons. So I do not know whether to boil down to saying mortality of ARDS in COVID is different from mortality of ARDS from other conditions. I guess you just have to struggle to filter out that information to get that definition. But yeah, overall, I agree with Peter. Thanks.
All right. So I'll go back to the patient. So basically, you're back to our patient.
A minute,
Yes.
Dr. Cornelius. Maybe we can take a quick question from Dr. Lillian Tugume, who had her hand up all this while. Dr. Lillian?
I apologize, Fiona. That was in error. I apologize.
All right.
Can we have hands up after the presentation?
Yeah. So
because we still have a long way to go.
Yeah, I encourage that we post our questions in the question and answer section, and we shall respond to those.
All right.
Dr.
So back to the case scenario. So this patient, again, 62-year-old, all these problems they're having, they are tachypnic, using accessory muscles, their SATs have refused to go above 85%. The question is, should we intubate this patient, or should we try something else first before we intubate this patient? So again, within the ICU, and do not think of a foreign country ICU. This is Uganda, and so we have to decide what we are going to do. So generally, before we got COVID-19, we had indications for intubation, and those included, and broadly, someone who has an endangered airway, and it could be as a result of reduced level of consciousness, at which point we say, yes, a DCS of less than 8 is perhaps a lot more associated with inability to protect the airway, or a patient who has rapidly reducing level of consciousness would require intubation, especially if you cannot reverse what's causing the reducing level of consciousness. And then failure to oxygenate, basically a saturation of less than 90% despite conventional oxygen therapy was also one of the indications. And then failure to self-ventilate, in other words, to breathe. And those are patients who may have an increased work of breathing. In most literature, you'll find that is considered to be a respiratory rate of more than 35, and the use of accessory muscles. Patients not able to complete sentences is a great indicator of their inability or their impending respiratory arrest. And then the other aspect is non-responsiveness in terms of hemodynamic instability. And when you look at all these, they all kind of lead into the classification of acute respiratory failure. And so if we are going to look at this patient that we just had, what do you think that we should, do they meet the criteria for intubation, or they don't? Okay, I tried to do something to fix the view. I do not know if the team can see this, the audience. However, I will let you know the results in case you can't. So I think so far right now, a majority are saying, above 80% are saying yes, this patient does meet the criteria for intubation. And a very small fraction is saying no. And another fraction is saying they don't know. Okay, we shall give this about a minute. Okay, about 82%, and the number is going up, are saying yes, this patient meets the criteria for intubation. 84%, the number is going up. Okay, so about, I think we have hit saturation point. So we are going to move into the next, sorry, let's move into the next slide. Okay, the second question in the poll EV is, what should be done in the ICU to improve oxygenation? Should we put the patient on A, high flow nasal cannula, or B, CPAP or BiPAP, or C, we do invasive mechanical ventilation, or D, I don't know. So what should we do in the ICU to improve oxygenation? Should we do high flow nasal cannula? Should we do CPAP? Should we do BiPAP as one? And then should we do invasive mechanical ventilation? Or we just don't know what to do for these patients? The answers here are quite interesting. There is a stiff competition, despite people believing that this patient meets the criteria for intubation. There's actually a stiff competition between high flow nasal cannula and CPAP or BiPAP, and they're both tied at about 38%. No one wants to do invasive mechanical ventilation anymore. It's interesting. Okay, about 41% believe CPAP or BiPAP should be tried. About 34% believe high flow nasal cannula should be done, and only 24% believe invasive mechanical ventilation should be done. Fortunately, no one selected I don't know. So I guess this patient would have their oxygenation improved somehow. So let's move into whether COVID-19 intubation should be any different, and we're going to discuss what we should do or what we could do and why the options may not be appropriate or may be appropriate. So early data from China actually showed us that China and Italy partly, they suggested early intubation, and that meant more than 6 liters per minute of oxygen requirement meant that you are going to get intubated. And then, of course, this was for the purpose of infection prevention and control because of the fear of contracting the disease. And then, of course, they were afraid that most patients would just crash. So this led to a lot of unnecessary intubation rates with no effect on outcome, as was revealed in multiple studies. Interestingly, there's been a lot of data on NIV failure, especially in de novo hypoxic respiratory failure. That simply means there is no underlying COPD in the patient, and you put them on NIV. Interestingly, the failure rates are actually not as low as we may think. They're actually high. However, there was a study that was done. It was called the Florari trial, and they looked at high flow nasal cannula use, and they showed perhaps better response in the high flow nasal cannula group than NIV. And so, although there's no evidence to justify or to support that we should use high flow nasal cannula or NIV, the Surviving Sepsis campaign recommended that we give it a trial of at least 1 hour to see if the patient would improve and hopefully avert intubation. However, they still go on and say that we shouldn't delay intubation, which is pretty confusing, because if you have a patient who meets the criteria and you don't want to delay intubation, but then you want to try high flow nasal cannula for 1 hour, that would sound like you're delaying. So it's unclear what it means to actually delay or to intubate early in this case. But what we know is that the Chinese and the Italians initially were intubating way too early, and maybe that's why they ended up seeing the L and H phenotypes, like Dr. Peter said. So there was a random systematic review that looked at observational studies and actually found no difference. This systematic review included about 9,000 patients from 12 studies, and 11 of those studies were in high-income countries, not low-income countries. Only Tunisia was a low-middle income country in that group. And then the limitations, of course, there was high heterogeneity, which means that there was the population that was selected was inconsistent. These were retrospective, prospective, all mixed up. And then, of course, the issue here was that there was no analysis based on the accepted indications for intubation. So we don't know if these patients were actually that sick to require intubation, and they just opted that they should try out high flow nasal cannula or NIV. These were, of course, not randomized controlled trials. So being observational trials, they do not control for any confounders, like patients being too sick to actually require intubation. So, and they also did not really analyze for that in this study. So they did justify the cause for delaying to intubate, but the question always is, and their definition in this systematic review was early is within 24 hours of arrival to the hospital or being admitted, and late is after 24 hours, anytime after 24 hours. But if we're using timing, then we are not using indication. So if a patient meets the criteria today, should we intubate or should we delay, because this systematic review said more than 24 hours. So how early is early and how late is late remains the question to be answered, and that remains relatively controversial. So when we look at the Surviving Sepsis campaign recommendation, if a patient comes in with severe hypoxemia and they have the indications for endotracheal intubation, by all means, do endotracheal intubation, let the expert do it, and make sure you're protected and minimize the number of staff. Whether you use a video laryngoscope or not may not be much of a big deal as long as you have PPE. If they don't meet the criteria, or if you think you can buy time, and most times, most recommendations will be not based on just hypoxemia, but based also on the work of breathing, then in that case, if the work of breathing is not so elevated, then you definitely want to try them out on supplemental oxygen, targeting SpO2 of about 92 to 96%, but you have to closely monitor these patients, perhaps in the ICU or an HDU kind of setting. And then if they're not improving, then by all means, you have to consider high flow nasal cannula. And if you're tolerating, then by all means, go ahead. And then if you're not tolerating that, then you probably are going to have to consider intubating these patients. And what we often use in monitoring high flow nasal cannula is something we call the ROX index. You can look it up, ROX, and that tells us who is likely going to need intubation. And usually don't take more than 4 hours to know who will probably need it, in case you're using high flow nasal cannula. And in case you don't think they still meet the criteria for intubation, then you can give them a try of NIV, but at this point, when you've escalated, this patient should be in the ICU, and the team to intubate needs to be ready within the hour. They must be monitored around the clock and given not more than 1 hour according to Surviving Sepsis Campaign guidelines. So you must monitor them. You must have their nursing ratios 1-to-1 to be able to know when to intubate and do it without delaying any worsening. So that's extremely important. Otherwise, what has been found is that patients who actually may need intubation and you delay, their outcomes are actually poor. So what we know is that the two modalities of non-invasive oxygenation may help avert the need for intubation and therefore reduce the resource consumption. However, those who fail tend to have much worse outcomes than those who are intubated immediately. So that means that there is a certain population that will fail NIV, and because you did not intubate them at the time you were supposed to intubate them, it does not matter whether you intubate them, they are probably not going to make it. And this is because NIV has been largely linked to what is called patient self-inflicted lung injury. And there is a very nice paper on this that was released recently from the Intensive Care Medicine Journal. I think if you just Google it on NIV, patient self-inflicted lung injury, you'll find that article. It elaborates on the physiology on how NIV may actually lead to increased lung damage. And then, of course, close monitoring must be done to avoid delaying intubation. The most important local perspective is that high flow nasal oxygen consumes nearly 5 times the oxygen that we need that we use when we are mechanically ventilating patients, and NIV consumes nearly 2 to 2.5 times that amount of oxygen. So before we go ahead and use these devices, we have to be cognizant of the impact that they will have on everyone else. And perhaps there may be room for us to allow what I would quote unquote say earlier intubation for patients who meet some level of criteria for intubation. We may have to allow a little bit earlier because of potential lack of oxygen enough to run these two devices, or in a situation where we do not have adequate monitoring, perhaps intubation may be a better option. And so these are things that you have to decide on individual basis, case by case. It's not recommended to just say, we shall intubate you tomorrow because we're supposed to wait about 24 hours. Each patient must be judged based on their status. So let's go into the panelists and see what they think about the timing of intubation, what guided their decisions, and what outcomes have they seen in this population. Over to you, moderator.
Yes, thank you very much, Cornelius. We can start off with Dr. Peter. Early intubation and mechanical ventilation versus high flow versus NIV. What has been your experience, Peter?
Yeah. So the way I look at this is all these are there are a range of therapies that you can use, but every single one of them is a trial until you get to intubation, because ultimately for us here, we can't go beyond intubation when it comes to supporting the cardiorespiratory system. So everything else before that is a trial. And if it works, then you go with that. But the trick here is in not taking too long to decide that this is failing, because when it fails, then you have a much sicker patient, and then the benefit of the next therapy also becomes questionable, because if you start the next level of therapy at a point in the patient's sickness when they are beyond salvage, then it is useless. So deciding whether to put a patient, let's say, to move from one of the low flow therapies to the high flow therapies, why would I pick high flow versus CPAP? Depends. If I have all of them available, then I'll probably start with the high flow nasal cannula. But yeah, so the high flow nasal cannula, and this one, what it really offers is a reduction in the work of breathing at the end of the day. So if I've got a patient who's very hypoxic, breathing very fast, these patients usually require a much higher inspiratory flow. And you can provide this with high flow nasal cannula. You could also do the same thing with NIV. The problems that I have with NIV are that you becomes very uncomfortable for the patient, and it's likely going to fail simply because the patient can't tolerate it. So I would go with the high flow first, and if it shows that it is improving the patient's condition, then we'll continue with that. And what I would normally look for here are things like, if the patient tells me they are feeling better, if their work of breathing drops, the breathing slower, heart rates drop, blood pressure drops, the patient just generally looks more comfortable. That's a patient who's doing fine on high flow. But if after 1 hour or 2 hours, they're not doing all right and none of those things has changed, it's probably time to move to the next thing. And you may give CPAP a trial, but I would probably just go straight away to mechanical ventilation. Yeah, so for me, the things here are, one, does oxygenation improve? Does the work of breathing reduce? And if we switch to NIV in most instances, there will be such a dramatic improvement in the oxygenation, but I think we tend to get blindsided by that improvement in oxygenation, and we ignore the other things like the work of breathing. And that means that oxygenation will be usually a late failure. By the time that happens, you've got a much, much sicker patient who may suddenly just stop breathing or have a cardiac arrest, or as you try to put them on invasive mechanical ventilation, you may lose the patient. So the trick here is in giving them a very brief trial and deciding whether that's going to work or not. But I have found that largely for the patients who we put these therapies on, a lot of things are not ideal. And they mean that at the end of the day, the therapy is destined to fail, okay? Some things like when we put them on CPAP, we put these masks on too tight, or we have masks that are not appropriate for the patient, or we don't have good, active humidifiers. So we are giving patients huge flows of very cold, dry air, and that just destroys the airway. Okay, you've got a patient who's terribly uncomfortable, and then you've got that mucociliary escalator that is just being destroyed. When you eventually intubate those patients, you have much, much sicker lungs. Okay, so they're just not destined to do well simply because of how you have cared for them before. I think I will stop there.
Mm-hmm. Yeah, thank you very much, Peter. Doctor, any comments on IMV, NIV, high flow, and are there stories of people who have eventually not been, say, intubated after using any of NIV or high flow?
You were breaking a little bit. Were you asking me or asking Dr. Mwanje?
Dr. Mwanje, Arthur.
Thank you. I also didn't hear you in the start.
Yeah,
as
I was
Peter
just
said already,
wondering whether you have any success stories regarding high flow nasal or NIV, or your comment on early IMV for the patients
yes,
that
of
you've
course,
been seeing in your experience.
Of course, I have very many success stories regarding all types of therapies, high flow, non-invasive ventilation, and invasive ventilation. It depends on the patient, as I said earlier. Managing this COVID patient should be individualized to that patient. And as the presenter said, you have to be there and monitor that patient and see how they change, their respiratory dynamics change. So that guides the next intervention, but for me, it has all worked. We started with high flow, then we went to, if it didn't work, we tried the non-invasive ventilation. We've had a patient, not one, not two, like maybe 4 patients. We've done non-invasive ventilation for over, I think, 2 weeks, and they have recovered and gone back home. So each therapy, I think, works. It depends on how you manage your patient.
Dr. Erasmus, what are your thoughts?
Okay, thank you so much, Cornelius. I guess my thoughts kind of cut across, but more importantly, I would like to highlight that I prefer to treat the patient, not the disease. And as such, the intervention must be selected specifically for the needs of the patient. These patients with COVID will present with different needs. Some need specific oxygenation needs, some need specific ventilation assistance needs. And you have to qualify a therapy for each of these indications separately. There are specific indications for providing better delivery of oxygen to a patient, and that is chiefly hypoxemia. And that is, say, hypoxemia that has not worked out with, say, just non-rebreather mask or something, and now you want to just go with a high flow nasal cannula for, because all you need is just to improve the rate at which oxygen is being delivered to this patient. That's a patient who has got good muscle function. They are breathing in quite fast because they're trying to take in as much air as possible, and maybe increasing the amount of oxygen flow into their body might help without increasing the risk of mechanical ventilator devices that might, without increasing the risk mechanical ventilation devices might have on them. However, a patient who is showing signs of muscle fatigue, signs of maybe declining level of consciousness, poor airway protection, increased secretions and the like, that patient may not be able to rate that, and so you might waste time. So as such, I don't have in my practice anything called the early or late. I believe that you have to qualify an intervention to the patient's needs, not qualifying a patient to an intervention. So as such, you need to first go through what exactly you want to address. The patient's hypoxemic. Are they fully conscious? Are they coughing strongly? Do they have limited airway secretions? Are they fully perfusing and good acid base, among other things? That patient just needs oxygen supplementation. And I mean, whichever means you choose, just remember the side effects of that. If you choose to use NIV for it, remember that you're inducing mechanical injury to the patient in a bid to increase oxygenation. But in that case, maybe a high flow nasal cannula might do very well. I don't agree with all the exaggeration of the actual reduction work of breathing some of these patients get from a high flow nasal cannula. Apart from improving the airflow in a patient who is probably extremely tachypnic, I don't believe it addresses a lot of the muscle. It does unload the work of breathing from the muscle aspect. And as such, trying to use it even as a trial, let alone a destination therapy, might be quite wrong. Similarly, when I find a patient who actually is using a lot of accessory muscles, like what's described in this case that Dr. Cornelius presented, of course, Cornelius didn't indicate what the flow rate of the oxygen on NRM was, but
15 liters.
Oh, 15 liters, okay, fine. Now, such a patient, probably needs you to help on top of increasing oxygen delivery to them, which you could actually do with a high flow nasal cannula. You probably need to be clearly evaluating this patient's work of breathing from an aspect of using accessory muscles and so on, and deciding whether that might be unloaded by just increase the flow rate of oxygen in them through a higher delivery device. And such a patient probably now fall in the range of going for either NIV or invasive. Now the question is, does the patient meet criteria for intubation, which you must qualify separate from qualifying a patient for mechanical ventilation? So a patient who needs intubation is someone who's not able to protect their airway. Probably patient is not able to cooperate at all. They are already altered. Maybe hemodynamically they're doing so badly, which means you expect they're going to deteriorate further. So perhaps that's where the debate of try NIV versus go straight to IMV might be valid. But in all truth, the next question for me will be, do you have enough oxygen? If you don't have enough oxygen supply in your facility to sustain care for that patient as well as other patients in your facility, you probably need to go to IMV, where you're going to ration oxygenation better, ration oxygen delivery better, improve lung mechanics, do better pulmonary toilet for this patient, and of course at the expense of probably increase the risk of invasive mechanical ventilation in this patient. It's how can I put it? So the other question you want to decide is if the patient meets the criteria for NIV, but also meets the criteria for IMV, in other words, just from an oxygenation perspective. I think that if you have enough oxygen in a facility, you may try to deal early. But remember, of course, you're going to interrupt that NIV so much. Even with helmet interfaces, you still have to interrupt it because the patient needs to probably feed or something like that, which definitely will mess up your progression with the care. But I guess far more important is now, what is the load of how well equipped and staffed is your facility to care for either kind of patients? For me, I feel at the end of the day, you have to answer those different questions to be able to individualize a therapy to a patient, not individualizing a patient to a therapy. Thank you.
All right, thank you very much, panelists. I think the message is very clear. Let's first of all, we need to individualize patients, and also if we decide to delay, we have to closely monitor these patients, so that in case they did not meet the criteria and they meet it, we are quick to intervene. Otherwise, any delay leads to perhaps non-beneficial invasive mechanical ventilation. Okay, so let's get back to our patient. So again, this patient has increased lack of breathing. They're using the accessory muscles. On non-rebreather, 15 liters, they are not getting any better. And so the team in the ICU decide that they're going to intubate based on the grounds that they have increased lack of breathing, and also they do not think this patient will respond to NIV. They're generally quite sick, and they think that the patient will stand a better chance at intubation. So if you're going to intubate these patients, the key points are to make sure that we keep ourselves safe. Of course, there's a bit of contention right now regarding the risk of intubation and getting COVID-19 in the ICU, especially. Again, if you look at the phases of COVID-19, usually by the time patients are critically ill, most of them may not be easily transmitting, but also intubation does not actually generate as much aerosol as we initially thought. And so, but setting up for intubation, of course, requires time. And it's always better to be already prepared to intubate any patient who you have in the unit. Having a minimum number of people is extremely important to avoid the risk of transmission, and then donning appropriately with aerosol generating procedures, N95, a visor, gloves and a gown and all of that are extremely important, or if you want to put on a coverall. Then, of course, using bacterial filters, bacterial viral filters, connected next or as close as possible to the patient, and then ensuring good communication. And we tend to do what is called rapid sequence intubation in these patients. In other words, we do not want to manually ventilate them at all. As soon as they are paralyzed by the medication, the tube must go in within a minute. So this is a very critical time. What we know from a study done before COVID, the Intube study, it showed the risk of hemodynamic collapse is extremely high, and these patients may sometimes come in severely dehydrated, largely because they've not been having enough intake, but also probably because they've been losing volume, especially those who have been having diarrhea, and then severe hypoxemia may actually happen, and they may actually end up peri-intubation cardiac arrest. And then, of course, the risk to the team, although this has become a little contentious with the minimal aerosol generation, but we have to, we try to use guides and checklists if we are going to perform this intubation to make sure that we are efficient, we achieve the goal in the shortest time possible for the safety of both the patient and the staff. So the patient is intubated, and I think it's now time for us to go into mechanical ventilation. As you can see, you have about a team of 4 people, but this is not necessarily needed. About 3 people at most, one that is at the head of the bed and is going to intubate the patient, basically is responsible for the airway, and that must be someone who has the expertise in airway management and intubation. And then you need an extra person who is going to handle the medication, and most times the same person will handle the monitoring, and then you need an extra person to help out, to be the airway assistant. Perhaps the other extra people you see here may be who are ready to, maybe they're coming to prone the patient after intubation. So now that we're going to mechanical ventilation, I think I'm going to just delve into the fundamentals of mechanical ventilation. But before we go into that, we have to understand how breathing works, because we literally have to mimic the way breathing actually happens based on different feedback loops into the brain and the effect onto the respiratory pump, in this case, which is the chest wall. Of course, the brain being the control center gets feedback from various parts, both the carotid body and also stretch receptors within the respiratory system. And then, of course, the lung, which is the membrane for gaseous exchange. So to allow us to be able to breathe, what tends to happen is that the brain sends impulses to the diaphragm and the respiratory pump, and that generates, we start to contract the diaphragm, and we generate a negative pressure. And with that negative pressure, we overcome the resistance that happens in the airways, all the way from the nose up to the 17th generation of the bronchi. And at that point, we start to have gas exchange beyond that point. So the air has to travel all the way to the alveoli, and there is resistance that happens, but all of that is overcome by the negative pressure we take in. And then, of course, to expand the alveolus, we need, again, the negative pressure, which is generated from the diaphragm contracting, more negative pleural pressure, and therefore air goes in because you have lower pressure in the lungs than the atmospheric pressure. Your alveolar pressure is negative, so yeah, air just rushes in. And that's basically how we breathe. The iron lung was perhaps the first mechanical ventilator that was unleashed in the 1940s when there was a polio outbreak. And as you can see, these were ventilators that existed in one big spacious room, and they put patients in there and they tried to get them, but of course not as effective as positive pressure ventilation. There may be a comeback of the iron lung, maybe, as you can see on the right side here. I do not know if it will work as efficiently, but perhaps it will have a role in the future. But it kind of tries to mimic the way we breathe by generating a negative pressure around the chest but before then they will just put the whole body in and the head is hanging out. When we go to mechanical ventilation, this is peculiar. The body should not be receiving positive pressure, and that has systemic effects simply because as we breathe in, the hemodynamic effects in terms of blood flowing back to the chest, the cardiac output may be affected somewhat. And then, of course, the drainage from the brain. So once you put positive pressure on the patient, the drainage in the venous end tends to be affected. And so if you're going to ventilate a patient, first you must understand the respiratory physiology in detail. And so in that case, the intensivist or the brain will be the control center. And then, of course, the effector would be the respiratory pump, in this case, both the chest wall, which the muscles and ribs, and the ventilator. In case you switch them off, the ventilator becomes the effector. And you, for example, if I paralyze a patient, then I have to become the brain, trying to get the feedback from what the patient status is clinically, what could be happening at the metabolic level, and therefore try to adjust the ventilator to meet the patient's ventilatory requirements. What happens at the lung level is less in our control, but we try to make sure that the patients are well oxygenated by how much oxygen we give them and how much pressure we allow the lungs to be at the end of expiration, as we shall see. So the only thing that we cannot replace really is the lung, but people have figured out how to replace the lung by using extracorporeal membrane oxygenation, at least for a time being, until the lungs start to recover. So if you're going to allow the brain to be functioning in the patient and determining how the patient breathes, you're going to have to understand how to synchronize the patient's brain and their mechanical capacity in terms of the respiratory pump and the ventilator. So you need to find a way of synchronizing the two. So if you're going to ventilate a patient, of course, you're going to use positive pressure. And like I said, again, you're overcoming resistance and you're overcoming elastance. And the resistance is really to the flow of air through, or oxygen through the airways. And the elastance, like I mentioned earlier, is the opposite of compliance. The lung is elastic, it's made up of elastin and collagen and all that. So once you try to distend it, it has a natural tendency to go back to its original position. So the alveoli tend to want to go back to their original position, and so you have to keep them open. So when we try to use ventilator modes, when we look at ventilator modes, we always look at what does the patient need at this particular time. And there are conventional modes that we tend to look at, and what we consider control modes. These are modes that we use, especially in the early phase when patients have just been intubated. And control here means I am fully responsible for the control in the patient, and their brain has been perhaps either switched off with the sedation, or the brain has been, or their respiratory pump, the muscles have been completely paralyzed. And in that instance, I want to control exactly the volume that the patient gets, or if I decide to set a pressure, the patient gets a particular pressure that delivers a certain volume. Now, of course, because of that, you find that there are what they call pressure modes in order to deliver pressure to the patient, or there are volume modes in order to deliver a set volume to the patient. And then in case you want to allow the patient to breathe, and this is where you're going to have a synchrony between you and the brain of the patient. So the brain starts to function, or the respiratory pump, their muscles and the ribs start to function. And so you have to find a way of synchronizing, and this is where you have SIMV modes, although these are less frequently used now. And then you have support modes that, in this case, the brain is fully responsible for how fast the patient breathes. It may not be fully responsible for how deep the patient breathes, but at this point, you can provide some support to enhance how deep the patient will breathe, but you have no control over how fast they breathe. You can only add an extra support to how they are breathing. And so when we did a study that hasn't been published, one of the residents, and we looked at some of the practices in our setting, and we actually found the majority of people were using the SIMV mode. We are yet to publish the work, and I think it's in the works right now. But you'll find that in other high-income countries, if you look at the Provent study that was done in one of the high-income countries, a majority of patients had pressure control ventilation being used, and almost no SIMV being used in that population. But I think when you're dealing with severe ARDS patients, there is room to move from control to support mode, depending on how the patient progresses, or you could just go through allowing the patient to breathe again and trying to synchronize with them, and then putting on the support mode when you're going to wean them off the ventilator. So when we are going to set mechanical ventilation, we have to look at how much carbon dioxide should be removed from this patient, and that hinges on the metabolic status of the patient. And there are things that you have to think about when you want to make sure that the patient receives an adequate minute volume. And for that, we usually set the tidal volume that the patient will get, or we may set an inspiratory pressure. Like I said, you either deliver volume or you deliver pressure, and then you set how fast that will be delivered. And that sums up to what we call the minute volume, and that deals with removal of carbon dioxide. On the other side, we can also look at oxygenation, where we are looking at the PEEP, and the PEEP is the positive end expiratory pressure, and that's the pressure that remains in the lungs when the patient passively expires and prevents alveolar collapse. It also enhances alveolar recruitment, and then of course maintains the airways open. And then the other aspect that we look at basically is the FiO2. So these are the two things that we want to look at when you're oxygenating. Of course, this is a skeleton of what I'm telling you. There are other things that may be part of improving oxygenation or playing with the minute volume of ventilation to try and optimize everything that you're seeing here. But in a nutshell, this is a skeleton of the basic thinking when we're trying to ventilate a patient. And so we go into the strategies for ventilating COVID-19 ARDS patients, and there are about 6 of them. The low tidal volume, PEEP optimization, FiO2 adjustments and recruitment, as well as prone positioning, sedation and paralysis, conservative fluid therapy, and antibiotic therapy, as well as looking at the VAP bundle, ventilator-associated pneumonia bundle of prevention. So if we start off with low tidal volume ventilation, basically what we are looking at here is Gattinoni came up with a concept of baby lung, and it's right here. So if you look at a patient like this was ARDS, there is a compartment in this patient. This is a patient who is in supine position. It's a CT scan, and you're basically looking at this area of the chest or of the lung that is completely obliterated. There is no gaseous extent, and then there is a component of that just above it that perhaps has ability to perhaps oxygenate and perform function of ventilation, and then you have a very small area here that is actually part of the gaseous exchange. And so it's basically the lung starts to behave like a baby's lung. So basically using very high tidal volumes, as was revealed in the ADSNet trial, actually showed an increased injury to the baby lung. So you have to care for the baby lung to prevent further injury, and therefore the more injury you get that can come from barotrauma, volutrauma, atelectatic trauma, and biotrauma can lead to multiple organ dysfunction. So in that trial, they actually found that using tidal volume, not 10 mils per kg like what Guytonian physiology used to tell us back in school, but using between 4 to 8 and targeting about 6 mils per kg predicted body weight. And predicted body weight is based on your sex and your height. So a man and a woman of the same height, simply because of sex, the man will receive a lot more volume by nature of men being men, and testosterone enhancing how big your rib cage will be and how high your total lung capacity will be. So this was the first step in individualizing how much volume we give patients. Of course, the other foundation of this is that if you are 60 kilograms today and you are 80 kilograms 2 months from now, your total lung capacity has not increased. It's only your fat that has increased. So you cannot change someone's tidal volume based on increase in their body mass. So the target of having this kind of strategy is that you will have a reduction both in the plateau pressure, and plateau pressure is really that pressure that allows you to expand the alveoli, not the pressure that allows you to overcome the resistance in the airways, but pressure that allows you to expand the alveoli. And that is very important because it actually is associated with outcomes, especially increased outcomes if it is high. But the more important aspect, and when you're ventilating patients, is the driving pressure. And the driving pressure, we really define this as the plateau pressure. In other words, the pressure that I need to expand this baby lung minus the positive end expiratory pressure. So plateau pressure usually occurs when the machine is delivering a volume or a pressure into the patient. And when you pause that delivery, so it delivers, let's say you set a pressure of 20 and you pause it at 20 for about maybe 5 seconds, the lung equilibrates. So basically this baby lung, you don't have any more flow of air and there's an equilibration in the entire lung. And that pressure that remains in the lungs when you paused it is what we call the plateau pressure, minus the PEEP that you've set on the ventilator. That gives you driving pressure. And the studies have revealed that driving pressure perhaps is the bigger determinant of outcomes and not just the low tidal volume concept. But we wait for trials to actually prove that to be true. And then of course, once you set the tidal volume, you want to set your respiratory rate. Oftentimes you want to set it about 70 to 100 mils per kg of predicted body weight, targeting end tidals of about 30 to 40. So maybe let's go into our panelists and see what they do, what modes they use, how do they do it any differently? Do they really care about the driving pressure or the plateau pressures? You can take it away, Fiona.
Yes, thank you very much, Cornelius, for that brief. Maybe I can start this time around with Arthur. Dr. Arthur, can you tell us your experience regarding the types of modes that you use at Mulago and how you determine this? Dr. Arthur.
Yes, thank you very much, Fiona. I think I've used all types of modes. And still, according to my experience, the outcome seems to be the same. However, with the new non-conventional mode, which is APRV, I seem to see a prolonged patient stay, unlike the conventional mode. But the outcome still, as I said earlier, seems to be no different. About the plateau pressures, these ones are also determined by the physiology of the patient. Because I've also come to realize that even ventilating patients should be individualized. You ventilate a patient according to their presentation. Generally, in the second wave, I've tried to use more of APRV, which I think helps patients to oxygenate better. But that oxygenation doesn't seem to change the outcome. Thank you very much.
Thank you, Arthur. Peter, could you make a comment regarding the modes of ventilation and how you've been using them to ventilate these patients, and also when it comes to predicted body weight, how do you go about it in the ICU? Do you have a way you measure the height of the patient in order to calculate the PW? Peter.
Yeah, thank you, Fiona. For me, it's a mixed experience, really. When I started out looking after these patients, it was APRV that we were using. But what I have discovered is that for a lot of these modes, there is a very shallow understanding of how to use mechanical ventilation with the patient. So I have really abandoned using one mode to ventilate the patients, simply because you find you work with a team of people, and it's probably better to use the approach that everyone else is comfortable with. So I wouldn't say I have a particular mode that I prefer. For me, the guiding thing here is, what is my patient like? And what do they need? And what can we as a team manage to give our patients? So I tend to go with what everyone else is comfortable with. But ultimately, the most important things are to protect the lungs, okay, and to meet the needs of the patient. So for a patient who's not oxygenating, you want to optimize ventilation to provide that. But at the end of the day, you also want to make sure they're still going to be ventilating well. Oxygen, the CO2 clearance is appropriate for the patient, but also the mechanics are appropriate for what you have. So when I get a patient at this, who I'm going to start on mechanical ventilation, the first part for me is determining the severity and the severity of the hypoxemia or the ARDS, if you like, and then also looking at the lung mechanics. And usually I start off with a volume control mode, because that just gives good or more reliable mechanics, things like compliance and resistance, and then allows me to see if these patients are recruitable. Now, once I know what those things are, then I may switch the mode to a pressure control mode, which for me just serves really two purposes, really. One is it tends to be a more comfortable mode for patients who are not completely paralyzed. So I tend to prefer the pressure control modes, but also simply because they don't put as much strain on the lungs as volume control modes. I mean, you could probably get the same volume in for less pressure. So I tend to go with those, but I don't think they are overall going to give you better outcomes than they are going to than you're going to get with other modes. It's simply a case of matching the operator with the patient and the type of ventilator and mode that you have. When those two things click, then you get good outcomes. That's it.
Yes, thank you very much, Peter. Erasmus, comment?
Thank you very much. Again, speaking last means that I agree with a number of aspects mentioned before. First, again, I think you have to individualize a mode of care to a patient. I do understand that we've never demonstrated any specific mortality or outcome benefit of any kind specifically to a mode of ventilation. Maybe because it's so difficult to boil down the outcome of a patient specific to a mode of care that they have received, since just a supportive measure. However, I still do believe that there are differences in the mechanics and therefore the impact of these modes on the patient's lungs in different conditions. And as such, an idea about what specific needs a patient has is needed. But whatever the case, the most important thing always about any mode is choosing what the operator is most familiar with. Because if all you know is the volume control, please stick with it, perfect it, and try your best to individualize different parameters of that mode to that patient's needs. In general, definitely, as we work in ICU, we realize that patients have different needs, and especially for COVID, at different stages, as already highlighted, they will have different needs in terms of flow, in terms of pressures, in terms of volumes, among other things, even time of inspiration and time of expiration, among other things. So getting familiar with different modes really helps, rather than trying to just put people in one box. I do believe there are modes that dissipate a lot more energy on the lungs, and these patients already dissipating a lot of mechanical energy onto their lungs because of maybe increased respiratory drives and taking large volumes, among other things. And some mods might not make great physiological sense to them. However, again, like I mentioned before, being familiar with the mod and being able to use to your best abilities probably counts more than the nuances of what specific differences each mod might confer on a patient. As for me, the first thing I always want to do for any patient who comes in is assess their clinical state. Look at how much their work of breathing is in terms of whether they're using accessory muscles alone or they're using accessory muscles and breathing quite fast, looking like they're taking large tidal volumes, among other things. That gives you an idea about the compliance in those lungs long before you even intubate a patient and start measuring it. Next thing is you want to examine that patient. I know that at the beginning of the pandemic, we're extremely scared of these guys like they were lepers, and we were not even touching them. We just wanted to shoot in a tube and move on. But now we have evidence that actually it may be safe when you are protected to actually stay around this spot to understand where they belong. Because in ICU, we treat one patient at a time. You have to take time to understand the patient. So I like to examine the patient and understand how they are breathing, appreciate what parameters of their respiratory work need me to focus specific attention to. I would like to listen to their lungs and see how badly these lungs are doing in terms of consolidations, in terms of crackles and regional mechanics, just to give me an idea. And if I have any imaging, it helps a lot from the beginning to predict what exactly I need to do. Overall, I guess in the first wave of COVID, we received most of our patients quite early. And by early, I mean somebody got a viral prodrome, they went to respiratory failure quite quickly, and they came straight to our facility. We received them, and we basically had a clear viral pneumonitis stroke ARDS in the offing with quite severe hypoxemia. The mechanics were quite great, and according to Gatnoni's description, the H type, so the L type. So these patients basically had increased respiratory drives with increased peak inspiratory flow rates. And I found that ventilate them in a pressure control mode, if I'm in control mode, or pushing them early to pressure support ventilation once they start improving was quite helpful in terms of helping me get them out of the woods. It's quite difficult to match the flow rates of some of these patients who are not paralyzed in a volume mode. And as such, I tended to avoid it, or at least try it and realize it was not going to work anyways for most of them. I tried to avoid muscle relaxation for way too long for most of these guys because they're already receiving steroids, and I see acquired weakness is a nasty outcome in these guys. And especially because they're already burning a lot of calories and they're likely to get weak with time. So I found that putting them on pressure control or pressure mode generally really helped a lot. I don't have a lot of experience with the APRV, mostly because physiologically, I just felt that perhaps it might actually cause a lot more energy dissipation in these lungs, in these patients. And maybe I'll learn a lot more to adjust the vent for these guys compared to other mods. And more importantly, I found that they were easy to ventilate from the time they arrived. In the second wave, definitely we've received a number of referrals who've been in a number of facilities already, or at least have received care at home. And by the time they come in, most of them are either getting extreme lung fibrosis or they have got sepsis, lung sepsis, or basically pneumonia on top, bacterial pneumonia, among other things, on top of the background inflammation. And the lung mechanics are quite different. Again, these guys still are driving in air quite too fast. And again, I found a little bit better help with pressure control. But I believe, again, a person who does volume control, a PRV, PRVC, whatever it is, might know very well how to adjust. It's really important to remember that you're managing two things. You're managing oxygenation, you're managing ventilation, which is CO2, but also you're trying to unload the muscles that are participating in the work of breathing. And whatever you do, whichever mode you choose, it's important to put those parameters together. That is really my take, and I still will keep bring this up. Every patient is unique. Every patient needs to be individualized. Care needs to be individualized to each patient. Thank you.
Yes, thank you very much. Back to you, Cornel.
Okay, thank you very much, everyone. So I'm going to try and move through this as fast as possible, since we are running short of time, and then we can have responses from the panelists at the end for each of the strategies. So looking at PEEP optimization and FiO2 and as well as recruitment maneuvers, there is a tendency for especially in North America, especially the US, to use PEEP FiO2 tables. Europe is more inclined to using the PEEP for the best compliance. And if we look at this table, right, rather this graph right here, you have volume on the y-axis and pressure on the x-axis, and this is what perhaps will form what is called a PV loop. So if our target tidal volume is 6 mils per kg, at the end here you have very low volume and very low pressure, and so you have a lot more collapsed alveoli. And this is not a place where you want to ventilate the patient from. So imagine a balloon that you're trying to expand. Of course, a balloon is a very simplified analogy, but the lungs are a lot more complex than that. But let's take a balloon. A balloon you're trying to expand, you need a lot of pressure just to start to get a little bit of volume of 6 mils per kg. And so the driving pressure at this point is extremely high because the lung is atelectatic. And so just like Newton said, it's easier for you to stay in motion if you've been moving than for you to start moving when you've been static. So it is extremely difficult to expand that particular portion of the lung. If you, however, so in that instance, the compliance is very low. If you, however, are able to expand the lung, then the driving pressure is dramatically going to reduce. And so you'll be able to deliver your 6 mils per kg with very little driving pressure. And therefore you have reduced force, reduced lung strain, reduced lung stress. And so you have less ventilator-induced lung injury if you have a better expanded alveolus. So you have a little bit of an extra pressure that allows you to have bigger volumes. And again, when you think about it, if you expand this, if you blow air into a very small balloon and you manage to get it to expand, you use a lot less pressure blowing into it when it's already expanded than when it was originally collapsed. And then at the other end of the spectrum, you start to get, the more pressure you have, the less volume again you have, but at this point you are over distended. And so at this point you are likely going to have perhaps barotrauma or volutrauma, depending on what you're doing. And you don't want to be up there because you have, again, a very high pressure. And when we look at pressure in this case, we're looking at its effect on the lung. And so it may actually cause a lot more injury to the lung and a lot more inflammation, and even worsen the patient's clinical status. So the general consensus, even if we do not have where to set, how to set the PEEP because we don't have trials, the general consensus really rhymes that PEEPs above 15 perhaps may be more injurious to patients and may not be beneficial based on this meta-analysis that was done. Again, the other aspect is that a fixed PEEP is inappropriate. You don't set a PEEP and you walk away and you come back the next day. Setting a PEEP also requires you to continuously allow adjustments based on the patient's conditions, variations. So that means you require, when you're in the ICU, you're probably going to have to view the patient at least four times in your shift or 6 times in your shift to make sure that the PEEP is well adjusted to meet the patient. Now, I'm not saying adjust the PEEP every hour. I'm saying adjust the PEEP based on the changes that you find in the patient and based on the targets that you have set for the patient. Individualizing the PEEP is perhaps where we are going, and personalized medicine, it's really time for us to do a lot more personalized medicine based on the patient's clinical status. And Erasmus likes to mentioned that word gestalt, so I thought I should slide that in. And then of course we know very high FiO2s, often above 60%, tend to have increased oxygen toxicity, based on the concept that we have a lot more oxygen radicals. Again, you already have a lot of neutrophils that are increasing the oxygen radicals, and then adding extra oxygen may cause more lung injury. However, if the patient needs it, the patient needs it, so you give it, and try to deal with the cause of the ARDS. And then of course, FiO2 adjustments need to be, especially the more severe the patient is, the lower our target. So in ICU, we adopt a concept called less is more. The sicker the patient, the sicker we let them be. So we don't try to push them beyond the capacity that they need. So again, the sicker the lungs, the more oxygen toxicity effect. So we try to target even a lower SpO2, but we've had issues with SpO2 readings in our setting, and sometimes it may be better to use a blood gas, especially if you're going to go for permissive hypoxemia, to be sure, because there have been studies that have shown patients you keep towards the 88s tend to be a lot more hypoxemic than patients you keep towards 96. These tend to be not as hyperoxemic as you may imagine. So if we look at recruitment maneuvers, there was, again, Gattinoni came up with the concept of open lung concept. And in that case, you apply a recruitment maneuver to open up a bit of more alveoli so that you have a better compliance and better ventilation and oxygenation in the patient. So this ART trial was done to see if recruitment maneuvers are really helpful, but it actually showed a little more harm than benefit. However, the limitations of this large trial left room for potential benefit in patients who could potentially respond to PEEP. And those are what we call PEEP responders. In other words, you give them a PEEP and their compliance gets better, their oxygen gets better. When you increase the PEEP even further, you start to see a good response in the patient. The breathing pressure starts to reduce. And so one of the limitations in this trial is that they did not actually categorize patients who are PEEP responders and non-PEEP responders. And again, this brings us to the concept that we need to individualize PEEP setting for patients and not just use PEEP FiO2 tables that adjust PEEP for whatever FiO2 you're on, like a robot. You may as well just put the algorithm into the ventilator and it does that. Otherwise, we have to think about the patient we have at the bedside. So recruitment maneuvers have now relatively been restricted to patients who are potentially PEEP responders, and perhaps as rescue techniques for those who are PEEP responders. So we shall not go into the discussion yet, we shall just go straight. And then the other aspect is prone ventilation. The ProSEVA trial, for about 8 years, the world of critical care has been applying prone positioning to ARDS. And of course, because COVID-19 is ARDS, it has become very popular even in North America, especially the US, but Europeans have been doing this for the last couple of years. It's perhaps the one study that has shown a huge reduction in mortality, 50% reduction in mortality. It's our most powerful tool, improves VQ mismatch, changes the gravity-dependent edema, and then of course allows for more lung recruitment. Of course, it's best combined with other strategies for maximal effect. And of course, the longer, the better, based on meta-analysis and systematic reviews. And so the physiology of proning, basically, if you look up here, the heart also has an effect on compressing on the posterior aspect of the lung. And yet when you prone the patient, there's a gravitational change that allows better perfusion ventilation matching compared to this position. And then of course, the liver, the abdominal organs will push against the posterior aspect of the lung. And yet we know that's where you have the biggest percentage of your lung. If you're doing prone positioning, you definitely are going to change that so the effects of the abdominal contents is reduced. So basically, prone positioning allows a more homogeneous lung to be ventilated than when the patient is not in prone position. So again, the CT scan images of proning, and as you can see, this is a patient who was in supine. The heart is right there. It is anterior, and then the patient up here is supine. There may be some improvements in the patient, of course, if you apply a PIP, but if you prone them, the improvement may be even much faster than if you left them in supine. So prone positioning is perhaps our biggest tool to overcome ARDS. And then the concept of paralysis, I think Dr. Erasmus has talked about that. Initially, a European study, Accuracy trial, showed benefit in using cisaltocurium. The Americans did a similar study with some bit of variation, and they didn't see any benefit, except that there was a lot more ICU-acquired muscle weakness. And then, of course, if you look at the meta-analysis, they have shown improved short outcomes like oxygenation and winning down the ventilation, but mortality was not different. So what we know is that COVID-19 patients may have a very high respiratory drive, and if you cannot sedate them enough to reduce their respiratory drive, and you have a lot of ventilators desynchrony, especially in the past 48 hours, then you could run neuromuscular blockade, either as boluses or as infusions. And then as we wind up, we look at, as well as fluid therapy, what we know is that fluids are drugs and must be treated as such. They have indications, they have dosing, and you have to decide when the target has been hit and you stop the fluids. So we know that cumulative fluid balance kills. This has been proven over and over again. I don't even need to put references to that. But from the FACTS trial, we know that if you can avoid IV fluid maintenance, you must avoid it. Things like keep vein open infusions, all those must be stopped. And so you have to avoid IV maintenance, because on top of having IV maintenance, we have those small aliquots of fluid that we give with drugs, and those can accumulate, and we call that a fluid creep. So over days, patients can become positive and cause a lot more injury to the lungs. So we only try to restrict intravenous fluids for patients who we can confirm a presence or suspected presence of hypovolemic shock. However, we prefer to go entero route to avoid any fluid overload, allow the body to take in what it wants to take in. And in case patients have a very high positive balance, we try to, we can use diuretics to, especially if they have signs of hypervolemia. We may not sometimes notice, but if the nursing team, which is really the backbone of ICU care, if they do not know or they do not do fluid management appropriately, the odds of saving the patients reduces dramatically. For every day that the patient spends positive, there is about a 10 to 20% increment in mortality. So we have to be very cautious when we're using fluids. VAP prevention and antibiotic therapy, we still don't have enough information to guide us on patients coming in with infections. It depends on where they're coming from and how they're coming in, but it's important for us to look for infection. COVID-19 patients are also at very high risk of having ventilator-associated pneumonia compared to non-COVID-19 patients based on this meta-analysis. But of course, that tends to come 2-3 days down the road. But whether they come in with a co-infection or a super-infection of either of these must be investigated. So it's important to do septic screen and developing local sensitivity patterns, and therefore be able to optimize the antibiotic therapy, but I'll leave the panelists to discuss more on that. So as I summarize the end of this discussion, the Surviving Sepsis Campaign guidelines do recommend everything that we've talked about, especially the first 3 things here, because those have an impact on outcomes. Conservative fluid strategy and empiric antibiotics may be used, especially at the point when the patient is admitted in the ICU, but it's important to investigate for bacterial infection and de-escalate antibiotics as needed. For patients who are potentially worsening and the ARDS is not responding appropriately, perhaps using a higher PEEP, and we usually say that's between 10 to 15. Anything above 15 may be non-beneficial. But again, it has to be individualized based on the patient. If I have a morbidly obese patient, I may actually go above 15. And then neuromuscular blocking agents may be used, traditional recruitment maneuvers, and these ones include just increasing the plateau pressure to 40 for 10 seconds, and then you adjust the PEEP back down, but this must be done for patients who are showing a response to the PEEP. Then prone ventilation and again using neuromuscular blockade for patients who have ventilator dysynchrony. So again, we talked about all this, but what we've not talked about is inhaled nitric oxide, extremely expensive, no data to suggest improved benefit, but there have been patients who have benefited from it. So individualizing it to patients is important. And then of course, VV ECMO is important for oxygenation. And so you can actually do more ultra protective lung ventilation strategies with VV ECMO. Yes, so finally, liberation from mechanical ventilators. We try to keep our patients as awake as possible as long as their requirements have reduced. And this is a picture of a patient that was published on CNN showing this gentleman playing his violin for the nursing team that was caring for him. He was a COVID patient, I think eventually passed on, but we like to see this in the ICU, and there's nothing wrong with having a patient awake with a tube in the mouth, and they are able to move out of bed and they're able to walk around. And so we have a bundle that we use in the ICU, and we try so much as possible to make sure that we do this for our patients. So basically spontaneous awakening trials when they are fit, allowing them to breathe as soon as possible to prevent diaphragmatic atrophy and failure to take them off the machine. And then of course, reducing effects of delirium. And of course, the earlier you mobilize them, the faster they recover from the disease. Thank you very much. I think I'll hand this over to the moderator for the further discussions.
Okay, thank you very much, Dr. Cornelius and our panelists. We are really running out of time, but I'll quickly go through the question and answer section to have these questions answered, and I'll ask that the panelists feel free to quickly respond to this to save the time. So Angelina Emmanuel says patients have many secretions, which they think it's due to the pathophysiology of COVID-19. So how do you go about intubating these patients with lots of secretions? Maybe Cornelius can answer this concerning personal protection.
So thank you. It's a good question. So interestingly, the secretions that you may be referring to are perhaps the deep-seated secretions. Most of the patients don't actually have overt secretions when you're intubating them at the time of arrival. Some of them are actually extremely dry, either because they've been on NIV that is poorly humidified, or they've been breathing pretty fast. So it's not common to see froth like you would see in patients who have cardiogenic pulmonary edema. They tend to have deep-seated secretions, perhaps, and there have been some studies post-mortem that have shown that. So what we do is put these patients on mucolytics, and I'm going to quickly answer the question of why we don't do bronchoscopy, because I suspect someone is going to ask that or will ask that. It is not routinely recommended to do bronchoscopies. I know there is that South African pulmonologist who in the first wave talked about that, and we did have a session with him and discuss what he does. He actually does not recommend the routine use of bronchoscopies. In fact, what he recommends is more routine use of mucolytics, because that tends to help patients to soften the mucus. So only for patients who meet that point at which you have to do bronchoscopy would you do it. So I hope that answers that question. Thank you, Phiona.
Thank you very much. From JH Wanuka says, why are COVID patients able to tolerate hypoxemia silently versus the traditional ARDS? Maybe Erasmus can answer this.
Honestly, it is still something probably under investigation, but the one thing that was observed in some trials is that a number of peripheral sensors for receptors for hypoxemia seem to be infiltrated by the virus in a number of patients. The reality is that not all patients with COVID will tolerate hypoxemia. It is just that a subset of people who, for some reason, come in with the so-called silent hypoxemia or happy hypoxia. In a few studies, when they looked at the neurons, they looked at a number of receptors peripherally, the chemoreceptors, they found that they were infiltrated by the virus. So it looks like these people can't then sense that they're extremely sick, and they'll be reading a newspaper till they get a cardiac arrest. So I feel in all my reading around the subject, it looks like the most plausible reason. The question also is whether these people have an isolated hypoxemia or pulmonary disease versus the other patients with other forms of ARDS that may actually come with multi-system disease by the time they present, which means already derangements in the oxygen delivery capacity in the body. We don't really know for sure how much hypoxemia a human being can tolerate and be okay, especially if other factors are all are constant. But we definitely know that prolonged exposure to hypoxemia, and especially the cause of hypoxemia, can increase your mortality, which is why most of these people suffer sudden cardiac death, among other things. But overall, maybe the answer lies in those two things. One, most COVID patients, especially those who come with so-called happy hypoxia, are seemingly healthy and fit people before, with good cardiopulmonary function before the COVID came and took out the lung itself, and the oxygen delivery, hemoglobin, everything seemed to be okay, and so they're able to maintain themselves for some time. But the bigger one really is just ability to sense that you've gotten hypoxemic. Thank you.
Thank you very much. And then to the panelists, how
Fiona,
often have you
could I just
successfully?
add something?
Sure.
Could I just add? Yeah. So the drivers of respiratory distress are usually things like CO2. It's only when your oxygen drops to PO2s of lower than 50 does your respiratory drive begin to respond to low CO2. So with most of these patients, the CO2 is not affected. In fact, it may be lower. They have an increased respiratory drive, and probably why they don't feel distressed is probably because the body demands for a larger tidal volume, and they get a larger tidal volume. The problems come in when they begin to get lung injury, and you have poor compliance, and the breath that you want, you don't get. And that's what causes them to feel distressed. But also, the human body is built with a lot of redundancy. We have got more red cells than we actually need. So even when the levels drop, when our SATs drop below 90, we're still able to deliver the oxygen that we need around the body. So these guys, they can make it. They're going to be fine, unless they've got some other problems, like Erasmus said. And so you find that we don't know the exact amount of the number of SAT that you need to get by in life. We don't know, because there are instances people have recorded, guys who've gone mountain climbing and they've got SATs of 68 and they're fine, they're walking around all right. So we don't know the exact level, but COVID seems to present some interesting situations. You've got patients who are hypoxic, but they don't have limitations in their lung mechanics. So they seem all right.
Yes, thank you very much, Peter. I'll allow Dr. Phiona to ask a question. Her hand is up. Dr. Phiona. All right. So to the panelists, how often have you successfully extubated a COVID-19 patient to recovery? There's someone who needs some encouragement here.
Erasmus can answer that one.
I can also try to answer. What I've seen with experience, there are patients, when you put a patient on a ventilator, you're likely to predict in like 2 days whether you will extubate that patient. Depending on how the patient responds to the oxygen responders, using the PF ratio, and the non-responders, or the carbon dioxide responders. Actually, we have a patient who is a carbon dioxide responder, and her carbon dioxide is around 100 PCO2. We are unlikely to extubate such a patient. So this can be predicted, and also depending on the lung dynamics, as you put the patient on the ventilator, you can see the compliance and the resistance when the lungs are being pumped with air. What I've come to realize, there are also a number of patients who have a higher resistance compared to the compliance, and they are also most unlikely to be extubated. So usually, according to my practice, I've seen extubating this patient comes within not less than, let's say, 10 days. Well, there are patients who have been extubated after 10 days, but mostly within the first 10 days, you're likely to extubate those ones who are to be extubated.
Okay. Thank you very much. Dr. Derek had a question. I saw his hand up. Dr. Derek?
Before Derek responds, can I just talk about the extubations? I think what most people forget is that these guys it's not just COVID, but it's critical illness. And it's not just, by the time these patients get into the ICU and we begin to do all these, give them all these therapies, it's a bit more now than just the disease. The patient must survive the disease, okay? And then there is a process that the disease has set on, and now the patient must recover, okay? There must be rehabilitation from that point, but also the patient must survive the therapies that we give them and the accidents that happen in the ICU, okay? It's a steeplechase or a hurdle, if you like. So you have a patient who comes into the ICU, hypoxic, okay, with this inflammatory syndrome ongoing, the hypoxia improves, the inflammatory situation goes down, but now you're dealing with a patient who has got a bacterial infection, okay? Maybe some doctor down the road started this chap on all these antibiotics, and now they've got some serious infection. We don't even know which antibiotic to start them on. Now they end up with sepsis. Now they end up with AKI. Then they die from AKI, okay? So the patient has to navigate a lot of things to, you know what, eventually survive the critical illness. That's what makes things difficult. But the patients do recover and the patients do get extubated, okay? It's just a question of the care team that is involved in managing these patients. And then of course, just bad luck that gets in the way sometimes.
Is there a role of surfactant or sildenafil? Any comment from the panelists and the main speaker?
My opinion, no.
There is, you know, I don't like a absolute no or a yes for anything. You really need to assess that patient at a given stage. There are patients who might develop pulmonary following pulmonary vascular resistance following the hypoxemia at some stage in their lives. But just giving it blindly, probably definitely no. Similarly, surfactant really, okay, for surfactant for sure. The problem here is not lack of surfactant, but the destruction of the capacity to make surfactant, and therefore replacing it seems to have absolutely no value in these patients. And as such, I don't predict any role for it, and I don't use it. Yeah, thank you.
The question I would like to ask Erasmus, for this wave and the last wave, how many times have you prescribed sildenafil or surfactant?
I have had just one patient who required it, but again, even for that patient, there was another underlying reason for which they developed pulmonary hypertension and just got worsened by COVID, at which point we had to worsen by post-COVID pulmonary fibrosis, at which point we had to add in sildenafil for care during the rehab phase. But otherwise, for most patients, we never did that. not this wave, not the previous wave for sure. But I do believe that there's always going to be a select patient out there. So I don't like blanket statements. They don't make sense. They're not medicine.
Well,
Any
I want
success
also
with
to,
yes,
I wanted to
Arthur?
give my submission about surfactant and sildenafil. I've used sildenafil and I've found some benefit. I've also used bosentan, but I think it does not apply properly in the setting of ICU when a patient is critically ill. But in patients who are still in moderate phases, I've caught some PEs and blindly before initiation of the therapy, I've given that sildenafil and it has worked for some patients. I think we need to do a study to justify that. However, there is a study that has been, it was conducted some time back about that same sildenafil, and it showed that there is some benefit when it's given to all patients blindly. I think you need to check it out. Yes. Surfactant.
I think
Sorry, moderator, I need to really highlight a few things. Now, you have to be very careful that most patients in acute or subacute phase of COVID are having extremely terrible shunt and and mixed with dead space, among other things, in their lungs, with other varying categories of VQ mismatch in them, and just using pulmonary vasodilators just blindly, especially in that stage, apart from just compromising your systemic hemodynamics, among other things, is probably not going to make a lot of sense. So you probably have to put in a lot more into figuring out who really needs it. And honestly speaking, I see struggle that anyone is going to probably benefit from these things in the acute phase, because again, much as during Dr. Cornelius' presentation, we had evidence of kind of a blighting of the pulmonary hypoxic vasoconstriction mechanism. It actually is not completely knocked out, and that mechanism kind of preserves the VQ matching in patients. I have been consulted on a few patients who actually were on that particular medication, and the numbers are definitely very few, and it seemed to appear the patients were having a lot more shunting than anything at that stage. And I imagine definitely in the chronic stage, you might try to experiment. You might treat that as a type 3 pulmonary hypertension at that stage. But I think in acute phase, it may not make sense. But again, a lot to be discovered. COVID is still coming, another wave. Thanks.
Thank you very much. There's a question here about the type of ventilator. Any success with a gradient CCV ventilator given our low resource setting?
I have absolutely no comment. I have not used it. I have not touched it. I thank you.
Okay.
Maybe just to make a comment on that. Most of even I think Mwanje, who practices in Mulago, have I don't use a gradient CCV. We have high-end ventilators. Gradient CCVs were mostly sent to the regional referrals. So as soon as the ICUs open up, we perhaps will see how well they do against ARDS. But for
Can I
now,
make a comment?
I don't think I have a comment on that.
Yes, Peter.
The gradient CCV, I guess the people who probably have the best experience with the gradient CCV is the Mbara ICU. And I wonder what their comment would be on how it performs with patients with sick lungs. It may be it may do okay with patients who have got healthy lungs, but you will have lots of other problems, especially if you have been working with the high end vents. So if I was going to make a prediction, I think if you have got your COVID patient with poor lung mechanics, you are going to have problems. You may not have a lot of options when you're trying to modify the care for these patients. But best people to ask, the Mbara team. They have been using the gradient CCV for longer than anyone in this country.
Yes, Mbara teams, you can put your comments in the comment section regarding your experience with the gradient CCV. Any comment on post-COVID?
Phiona, the Lacho people
yes.
also are using the gradient.
Okay. Thank you very much. Please put your experiences in the comment section. Any comment on post-COVID respiratory distress, aspergillosis, and lung abscesses? Any experience with that?
Yes, I seem to have some experience with those patients. Actually, all patients I've seen post-COVID with respiratory distress, we've done bronchoscopies in them. And we've found a lot of pus. Actually, all of them have not survived. We've found pus in their lungs. We've also found some kind of blackish lining inside there that looks more scarring. One had pus and two, I think four had a lot of pus. We tried to suction, but I think it could not all come out. With scarring and some, I don't know, I can explain this. We try to take off samples so that we can do histopathology, but I think our findings could not find the patients. So I think it's a really bad presentation in post-COVID patients if they come with aspergillomas and lung abscesses.
Okay, thank you very much. A question from Andrew
May I
here.
comment? Sorry, may I comment on that? Sorry.
Sure.
I know that we made time. My experience, if you survive ICU, get extubated, and then you have this respiratory distress, it is quite infrequent that you have gone through that journey and carried on some sort of bag, especially fungal bags in these patients. Most patients get their fungal bags while they are still on vent, and usually directly related to a background of having, been on extremely high doses of immunosuppressants, especially high doses of steroids. People are now excited to use new biologics coming in, things like tocilizumab, among other things. Used recklessly, for sure, they are bringing a lot of things. I've never seen mucormycosis amongst my patient cohorts, and I do culture patients quite regularly. And yes, we should probably catch something. Post-COVID respiratory distress seems to be more about the chronic changes chronic lung disease patients tend to get. So we're talking about restrictive lung disease. These guys get fibrosis, which restricts lung capacities, so they're always breathless. They develop some level of pulmonary hypertension in the background. And we've talked about the pathophysiology of the disease, which includes things to do with microthrombosis, which really increases pulmonary resistance in most of these patients. So, and then because they have been ventilated for a long time on a disease that affects the pulmonary resistance for so long, most likely on high pressures, many of them might actually have a level of right ventricular dysfunction, which might drive that breathlessness that we see. So I think these patients need extremely meticulous workup, cardiopulmonary workup, other than, but definitely still, if a patient has had quite a bit of fibrosis, for sure infectious workup needs to be high on the list. I honestly have not got experience in our cohorts with aspergillosis, despite seeing a number of them. Thank you.
Yeah, someone was, I think Dr. Derek was putting in the comment section that he has had an experience with the gradient CCV, but only for transportation of a patient, and had to take the patient to where they can get a high-end ventilator. Though we are still waiting on those comments about their experience with the gradient. And that brings on another
Phiona,
question about, yes, Dr. Cornelius.
I think George Katerega can let us know. He's online. I don't know if he wants to make a comment. But
Katerega George from Bara, can you make any comment on your experience with the gradient CCV?
Well, thank you very much for the good presentation on this topic. In Bara, we have actually not been very keen on actually intubating these patients and mechanically ventilating them. So as far as use of the gradient is concerned in these patients. We don't have any experience in COVID patients. In other ARDS, we've not found any problems yet. Thank you.
Thank you very much, George, for that question. There was a question that goes to the panelists still about use of steroids, antibiotic cover, where you have all these investigations. You can look at your septic markers and all that. Could you still blanketly use steroids, and what is your experience?
I'll go first.
Yes.
In a way to complete my previous submission, there is a category of patients post-COVID who have been on a lot of steroids. You get them off the ventilator, and then when they turn off the steroids, they develop a COVID-like lung inflammation post-resumption of the immunity, which really suggests some sort of category of patients with a post-COVID iris. And these patients might need to be followed for a while. There are a number of patients who've been following for the last 3 to 4 months, doing follow-up CT scans. And we've had to put them back on steroids for a period of time, and then these changes disappear. Perhaps that's something to keep at the back of our minds as well. Some sort of post-COVID interstitial lung disease or something, or post-COVID iris. We have to think about that. Now, the question of use of steroids. My use of steroids really is born out of the pathophysiology of the disease, where we know there's quite a strong pro-inflammatory aspect to it in the early phase of disease. And thereafter, you might go into the fibrotic phase, infectious phase, and the like. So if a patient presents usually in the first week or so, and the evaluation suggests it may be less likely to have a bacterial infectious issue, then perhaps steroids may make sense. However, how much to use is a big question. And most times we've tried to go with the trial from the UK as well. Just to go with 6 milligrams. But in people who have got extremely florid lung inflammation, the highest we've really gone is, say, 8 milligrams BID initially for the first 1 to 2 days, and then progressively taper down to 6 milligrams daily for a maximum of 10 days as per the trial. But in that period, we're really looking for any signs of infection in patients so that we can actually discontinue steroids as early as possible. Otherwise, they go into an immunosuppressive state. Beyond the first 7 days of illness, I've only seen steroids increase the risk of sepsis, especially fungal sepsis, and probably wouldn't be advising their use. Thank you.
Thank you very much, Dr. Cornelius. Thank you very much, Dr. Erasmus, Dr. Agaba, and Dr. Mwanje, our panelists. Thank you so much to the 100 and more participants that have joined this talk. Unfortunately, we have run out of time and we cannot continue, but this talk is going to be available on the AAU website. You can continue to listen in and put your comments there. And you probably, the panelists, will also have some comments to answer all your questions. Unfortunately, we've run out of time. We cannot continue with the discussion, but we really thank you so much for the participation. I'll ask Dr. Cornelius just to give us a take-home message, maybe in 1 or 2 sentences. Thank you.
Okay, thank you very much, Phiona, and thank you everyone for attending this. I hope it has been beneficial. I think from this discussion on COVID-19 ARDS, I think the clear message is that we are all learning as we go along. These patients are extremely challenging. Ventilating them is not as easy, or not as easy, but not as straightforward for most of them. And then we've seen that they can easily get hospital-acquired infections, especially ventilator-associated pneumonias. So we have to be careful with how we handle them and make sure that we avoid them getting to that point. You can easily treat the COVID-19 and get rid of it, but it's been the bacterial sepsis and the fungal sepsis that has been the biggest challenge in these patients, especially beyond a week in the ICU. So I think with that, I would like to bid you all a good night and thank you for attending. We hope to see you next time. Thank you, Phiona.
Yes, thank you very much, everyone. My personal take home is that individualize each COVID-19 ICU patient. Less is more. And you have to have a very good background of your ventilator, good background knowledge of your ventilator in order for you to be able to properly take care of that ICU patient. Thank you very much, everyone, and have a good night.